and I would invite the third speaker, Dr. Bhaskar Srinivasan, who would be speaking to us on dry eye and systemic disease.
A very good afternoon. No financial disclosures. So basically, when you're looking at dry eye and systemic disease, you're probably looking at primary, secondary Sjogren's, SJS, OCP, GVHD. These are the common conditions that you'll be looking at. My talk would primarily focus on the primary and the secondary Sjogren's. So when you're looking at a patient with a collagen vascular disease or an autoimmune dry eye, you're looking at either dry eye, you're looking at scleritis, you're looking at necrotizing scleritis, sterile melts, and then when you have to do a cataract surgery, and then you need to know how to plan the surgery. So when you're looking at dry eye, you're looking at the aqueous tear deficient patients who generally tend to have a history of dry mouth or a history of small joint pains. They could be on other medications which could actually aggravate their dry eye. And once you have ruled out any other cause, then you would want to investigate them to find out whether they fall into the primary or the secondary Sjogren's. Sjogren's thing. So sometimes it might be the ophthalmologist who would identify it and refer it to the rheumatologist, and sometimes it might be a known rheumat patient who the rheumatologist is referring across to you to take care as far as the dry eye part is concerned. How do we evaluate them? Obviously, you would be looking at a questionnaire. You could look at quantification of the tears with the Schirmer's, with the tear meniscus height, the lacrimal gland flow, which Sayan mentioned. Osmolarity is more of a research tool. You would look at the fluorescein grading or staining of the cornea and the ocular surface. You would look at the breakup patterns and the time of breakup, which would tell you what is the severity of the aqueous form. And for the meibomian gland, you would probably look at the meibography, and you would look at the lipid layer thickness, which would give you an idea, and the expression of the meibum, which will give you an idea about the extent of meibomian gland dysfunction. How do we manage them? Obviously, it's going to be a step ladder pattern, which is Dr. Sangwan already mentioned. Based on the severity, you would need to see which is more contributing more, whether it is the ATD which is more or it is the MGD which is more, and then base your treatment algorithm based on the Deuce 2 or the T-Ford classification. So if you're looking at an ATD component of dry eye or Sjogren's, why are you worried is because these eyes might have significant staining of the ocular surface, which could result in a breakdown of the ocular surface, resulting in infections or melts. And we want to intervene because we want to improve the symptoms, we want to improve their vision, and if we are planning an elective surgery, we want it to go uneventfully. If you are looking at how do you address them, obviously lubricants are our first medication. We would be looking at immunomodulators in the form of cyclosporin. But in certain situations, for a short period of time, you might want to use topical steroids. Topical steroids are not to be used on a long-term basis. These are just for that acute exacerbations. But what is important, especially as far as Sjogren's syndrome is concerned, is to manage the disease with the help of a rheumatologist, and you would need to control the disease with systemic medications as such. So if the disease is not getting controlled with the topical drops, the immunomodulators, you need to use steroids more often, then you're looking at going to the next level of treatment where you would be looking at blocking the puncta, whether with plugs or with cautery. And how does this help? Is it basically stabilizes the surface by retaining whatever tears are there on the ocular surface, reduces the need for us to put the patient on regular bouts of topical steroids, and makes them less dependent on the lubricating drops. So let's go through certain cases. This was a patient with joint pains, with dry mouth, with dry eyes. She already had a LipiFlow done elsewhere with very minimal improvement in symptoms. Serologically, she was negative. So this is the eye and the findings. So very low Schirmer's, TMH is low. There's a diffuse staining on the ocular surface, not much of flow from the lacrimal gland. So already most of the treatment algorithm was already done. Lubricants was already on, cyclosporin was already on, LipiFlow was done. So then we had two things to look at. One, whether there's a systemic component to the disease, and second, what we can do to improve the aqueous phase as such. So when you look at the LipiFlow and the IDRA here, again, it does show a decrease in the lipid level, but not a very sick. So you still have ATD component which is more, but MGD component is also there. It's not that a pure ATD component is there. So this was diagnosed as a level 3 Deuce, significant ATD with MGD. Blood tests were negative, but the rheumatological consult revealed it to be a negative RA, and this patient was then started on medications for her RA and also underwent tear conservation strategy in terms of a punctal cautery. And post-punctal cautery, there was a marked improvement in the ocular surface with the Schirmer's value improving, the TMH improving, the surface staining significantly reducing. Even in the investigative tools, you can actually see an improvement in the blink. You can see an improvement in even the lipid layer, because once your aqueous phase improves, the lipid layer also spreads a little bit better. So the value that you get in terms of the machine will look a lot better. So that was with the IDRA, and this is with the LipiView, where you're actually seeing the lipid layer of almost 100. So when you're looking at any of these equipments or machines, if you see a value which is too high, you can still have to sometimes take it with a pinch of salt, because if it's a diffuse staining surface, also the LLT might actually be high because it's not spreading across the surface. Similarly, just addressing the aqueous phase also might actually improve the lipid level, because it allows the lipid to spread better on the ocular surface. So this is actually the LipiView showing the pre-cautery phase, where you can hardly see any movement of the tear film. You can see it's lackluster, and here the lipid level also, you're not doing anything to the lipid, but just the fact that the aqueous is there, your interference pattern is a lot better post-cautery. So case 2, this was a patient with RA with secondary Sjogren's who had undergone cataract surgery. Post-cataract surgery, there was an epithelial defect. Patient was uncomfortable, again had LipiFlow done, but it was not improving. It was almost about a month post-surgery, and she presented one eye with a central defect which was non-healing, the other eye with a diffuse staining. So here also you have already gone through all the measures. Patient is on cyclosporin, has had some sort of plugs put initially, which was not responding to that. Patient has had LipiFlow, so you need to take the next step. So here again, the investigation is showing a decreased tear meniscus height. Meibography doesn't show a significant gland dropout. So here we are basically looking at more of an ATD component. The MGD was very mild. We went ahead and did a cautery, and just it's almost like 1 or 2 days post cautery, the defect has almost healed. The surface staining has improved. So it's important to identify the component which is more causing the issue and treat that, and address any other issues also. Again, this patient was also referred back to the rheumatologist to hike up the systemic medications, understand the disease activity, and be sure that that is not something which is aggravating the dry eye as such. So when you're looking at a patient with systemic condition with dry eye, you need to be in liaison with your rheumatologist. If you don't have access to a rheumatologist, this was a guidelines which the Cornea Society of India came out with in consultation with a rheumatologist as to what are the investigations that you can do. But it's always better, because sometimes if it's a seronegative case, as ophthalmologists we might not understand what is the clinical diagnosis. It's better to keep a rheumatologist in the loop, and they will help you guide the treatment in these patients. So how do we monitor these patients? Obviously, once you have stabilized and noted that yes, it's a Sjogren's or a secondary Sjogren's, you would want to see them every 4 months to 6 months. And if there is a worsening, obviously they'll come back earlier. But if there's a worsening of the dry eye and you have addressed everything else, then you will want to probably refer the patient back to the rheumatologist to assess the systemic condition and decide on hiking up of the systemic immunosuppression. So what would be ideal situation would be, we should refer all our severe dry eye patients to a rheumatologist to rule out a Sjogren's, and rheumatologists should ideally refer all their rheumat patients to us to identify dry eye, because a lot of times symptoms and signs do not match. So if they are just waiting for the patients to be complaining of dry eye, we might miss, because sometimes the duration of the disease, their symptoms become much lesser. You might actually see a lot of staining on the surface, but the patients might not be complaining, which doesn't mean that he or she doesn't have dry eye. It's actually a ticking time bomb, because the surface can break down anytime, and then you'll end up with a bigger problem. So the other thing that you would see sometimes is peripheral and paracentral melts. Paracentral melts are generally more associated with dry eye. Peripheral melts are generally supposed to be more associated with immune melts. It's not sacrosanct, you can have both, but that's the general guideline that you would want to look at. And obviously, if it's an impending perforation, you would need to address it with measures in terms of cyanoacrylate glue or a patch graft to make sure that you don't end up with a perforation. But what is important, if you have a peripheral melt, is it is indicative of a vasculitis. You will need to get in contact with your rheumatologist, hike up the systemic medication, because this vasculitis can be life-threatening. So it gives you the timeline that no, this is not a normal dry eye alone. You need to act fast. You need to pump in systemic immunomodulators in terms of IVMP, or hiking up the systemic medications with the help of the rheumatologist to save not just the eye but the life of the patient. So this was a patient who presented with inability to open the eye. She was a known RA patient, significant filaments on the surface, diffuse staining on the surface. You can see the number of filaments there. We initially started medications. She improved a bit. Then we did a cautery. She was stable. But you can actually see after that also, you can see peripheral thinning, which indicates there was some amount of activity which was going on. We hiked up the systemic medications. Then she was stable. The parameters post-cautery were also fine. She comes with a sterile infiltrate and a little bit of a thinning. Again, hiked up the systemic medications along with topical steroids to control the inflammation. She was stable for almost 2 years, and then she comes with a worsening. So we've already done everything from the eye point of view. The puncta is blocked, drops are on, topical cyclosporin is on, she is on systemic medication, and then she comes with a worsening of her dry eye. We tried, okay, fine, we said we'll give her autoserum tears, marginal improvement. We gave her an option of using a prose lens. She was not comfortable, but something was not fitting into it because she was stable for 2 years. So we referred the patient back to the rheumatologist, and he identified that her parameters had actually worsened and he had to hike up the systemic medication. Once the systemic medication hiked up, the ocular inflammation significantly came down. So again, when you're looking at this patient who stopped his systemic medications in terms of RA patient, one eye is showing diffuse staining and the other eye is having a peripheral melt. So like I said, a peripheral melt in an RA patient is indicative of a vasculitis. Tectonically, you stabilize the eye, but what is more important is you need to refer the patient to a rheumatologist for systemic medication. So that's important. In terms of other inflammations, scleritis, almost about 50% of patients with scleritis, just a couple of minutes, 50% of scleritis will have underlying RA or a GPA. So necrotizing scleritis is an ophthalmic emergency, not just from the eye point of view, from a systemic point of view. And these are just photos of patients with RA having peripheral scleral melts. This was actually postulated by Foster long back, that development of rheumatoid associated PUK is usually a sign of progression of life-threatening systemic disease and is associated with increased mortality and ocular morbidity. So it's very important that you realize that you have a peripheral melt, you have to get in touch with your rheumatologist. Again, when you're looking at elective and emergency surgeries, we need to improve the ocular surface before we plan the surgeries. So you would want the disease to be under control, continue the DMARDs, you don't have to stop it. You might want to continue steroids in the perioperative period if the disease is not under control completely. Emergency surgery, obviously it will be an IVMP or a pulse endoxan and you continue with the surgery. Refractive surgery, at this point of time, probably the consensus is bearing ICL, we would not be doing any laser-based refractive surgery in a patient with a primary or a secondary Sjogren's as such. You have something called as a plus disease where you're going to be missing either an SJS or OCP, or you could have a combination of Sjogren's with SJS and OCP where you see cicatrization. Primary Sjogren's, the risk of cicatrization is not so common. So if you're seeing cicatrization, think of conjunctival diseases which can cause cicatrization. This patient was being treated as RA with methotrexate for a long time, and we actually realized that this is not RA. You can see the cicatrization which was suggestive of ocular cicatricial pemphigoid, and finally once with systemic medications we were able to salvage both the eyes of the patient. So cicatrization is not common, it's not a common feature of a primary or a secondary Sjogren's. If you're seeing cicatrization, think of some other causes. Thank you.